In my next 20 minutes, I hope to cover the CT features of the idiopathic interstitial pneumonias, focusing on the fibrosing interstitial pneumonias, which I think are the most common diagnostic challenges in ILD practice, in fact, and also to talk a little bit about the multidisciplinary diagnosis. So this you're familiar with. This is the grid that we produced in 2002 with the ATS-ERS classification of idiopathic interstitial pneumonias. We, as radiologists and the pathologists, are morphologists. So these are the patterns we recognize. These are patterns of lung injury. And when the clinician identifies an associated morphologic clinical syndrome that's idiopathic, the clinician can apply the label of, for instance, idiopathic pulmonary fibrosis, idiopathic NSIP. So our job is to speak the pattern language and give a differential diagnosis. The clinician gets to assign the disease or clinical syndrome label. So what's going to happen next? Well, it turns out that nothing stays constant. There is a 2012 revision that's in reasonably advanced phase of completion. And the good news is there really isn't that much change, just update on our understanding. So that's mainly what I'm going to present today. So these top two, usual interstitial pneumonias and NSIP, have been grouped together now as the chronic fibrosing interstitial pneumonias. The next two, DIP and RB-ILD, are grouped as smoking-related interstitial pneumonias. Then these two, organized pneumonia, DAD, are grouped as acute or subacute interstitial pneumonias. And it's been recognized that lymphoid interstitial pneumonia is a very rare entity, and it's moved into a category with a couple of other rare entities. I'm not going to, for time reasons, I'm not going to talk about diffuse alveolar damage. We'll focus most of our time on these top two. It is important to know the relative frequency. In your practice, you should expect to see UIP most commonly, and NSIP is the next most frequent, along with the smoking-related lung diseases. Organizing pneumonia is not a common disease, at least the cryptogenic form, and DAD is actually not that common either, and as I said, LIP is pretty rare. The reasons that it's important to make this distinction are on this slide. If you, as a radiologist, say that you see a UIP pattern, then you are telling the patient that their 5-year survival is about 40%. That's worse than breast cancer, better than lung cancer, but it is an important responsibility to make sure you're doing that right. So these criteria were published last year with the ATS-ERS statement on idiopathic pulmonary fibrosis. Basically, the process, the flow chart is suspected IPF. If you have an identifiable cause, then you clearly don't have IPF. You just go into some other algorithm. If you think it is IPF, the next critical thing is HRCT, and our task as radiologists is to identify whether the CT pattern represents the UIP pattern, in which case the patient receives a diagnosis of IPF, or whether it's possible or inconsistent, in which case the patient receives a lung biopsy and multidisciplinary diagnosis. So this is the language we should use. UIP pattern, possible UIP, inconsistent with UIP. And we'll go through the criteria for each of these. The diagnostic criteria for UIP have really changed very little over the years. It requires a subpleural and basal predominance with reticular abnormality and honeycombing with or without traction bronchiectasis. And you have an absence of features inconsistent with the UIP pattern. And we'll go through what those features are. I use coronal images, and we do routinely coronal images, but I find them particularly helpful for identifying the distribution of disease, and also somehow it's often easier to see the honeycombing on the coronal images compared to axial images. So this is a typical UIP pattern. This patient has UIP and usually would not require a lung biopsy. Now, the possible UIP, the only difference in these criteria with the ones I just showed you is the absence of honeycombing. So honeycombing is the pivotal distinguishing point. We do have to understand that there is a substantial minority of cases, or sometimes majority, with UIP in whom you can't make the diagnosis because there is no honeycombing. Those people need to go for biopsy because the features overlap with other lung diseases. So honeycombing is present in about 70 to 80% of UIP. It's the strongest indicator, and it does have prognostic significance. If you have UIP with honeycombing, about a 2-year median survival. Without honeycombing, survival seems to be longer. Whether that's because of earlier disease or a different disease phenotype, I think is unclear. So I think our most important job and the commonest issue we see in our practice is people being overdiagnosed with UIP, right? Radiologists in the community tend to overdiagnose UIP. There are actually papers that show that. So and usually it's for one of these reasons. These are the features that should lead you to say this is not consistent with the UIP pattern. Upper or mid-lung predominance, peribronchovascular predominance, extensive ground glass abnormality, profuse micronodules, predominantly in the upper lobes, discrete cysts, diffuse mosaic attenuation or air trapping, or consolidation. What's the reason this patient is inconsistent with UIP? What's the diagnosis here? Hypersensitivity pneumonitis with mosaic attenuation. Good. So this, just to reiterate, if you make a first choice diagnosis of UIP, you'll be correct about 85 to 100% of cases. If you make a confident first choice diagnosis, which usually means presence of honeycombing, the positive predictive value of that is over 90% in many series. But there is a substantial majority or minority of cases in who have histologic UIP who you can't make the diagnosis, and those are the cases that still need to go for biopsy. And so this paper was published a couple of years ago because now that we're so good, the only people who are going for biopsy are those that don't have typical CT appearances. So Dr. Sferzolati found that only of people who had undergone biopsy, only 20 had high probable diagnosis of UIP, which is actually appropriate. And then the rest of them overlapped with CT appearances of NSIP, chronic HP, or sarcoid. So that's just a fact of life. There are some cases of UIP that have atypical features. We think that those people behave better than classic UIP. A couple of other imaging points about UIP. First is, this is a thing you will see. Here's a patient with moderate UIP, comes into the emergency room, hypoxic and short of breath, gets a PECT 5 months later, diffuse ground glass abnormality. What's the diagnosis? This is accelerated deterioration in IPF. It's a relatively common cause of deterioration and of death in the IPF population. And you, as the radiologist, really should suggest that diagnosis. Obviously, there's a differential including infection, maybe lung edema. Usually they'll get a bronch and lavage to exclude infection. The other important thing for us to look for is lung cancer. Probably somewhere around 5 or 10% of people with UIP get lung cancer, and the problem is that it hides out in the areas of fibrosis, so it can be very subtle, particularly in the early stages. So it's peripheral, lower lung predominant, maybe multifocal, and so you need to have your eyes open if you see any sort of solid mass in those people. So now we move on to NSIP. NSIP usually presents with a fibrosing interstitial pneumonia. It's usually fibrotic. Remember all that thing about cellular NSIP and fibrotic NSIP? The vast majority of them are fibrotic. So the key points are, as I showed in that earlier slide, it does have a substantially better survival than UIP. And the other key point is that when you have an NSIP pattern, you have a pretty high probability of having an underlying condition, either collagen vascular disease, hypersensitivity pneumonitis, or drugs. So always bear that in mind. And if you look at the literature on the CT appearances of NSIP, it's very confusing. But there is a particular CT appearance that we've learned to recognize that is pretty highly suggestive of this diagnosis. And it's characterized by basal predominance, so that's like UIP. But in contrast to UIP, it tends to be more peribronchovascular with sparing of the subpleural lung. And that's a useful diagnostic sign. It tends to be more confluent than the patchy distribution of UIP. Often you'll see a lot of lower lobe volume loss. Look at those fissures. Those lobes are really small. You will see quite a bit of ground glass abnormality mixed with reticular abnormality. Often you'll see traction bronchiectasis. Almost always you'll see traction bronchiectasis. You may see some consolidation. Honeycombing is uncommon and should suggest UIP. All right, so I'm just going to show you a couple of other examples of this. Coronal images, again, are very helpful in showing this confluent peribronchovascular distribution and the marked traction bronchiectasis and lower lobe volume loss. Typical NSIP. Here's another example. Traction bronchiectasis, some ground glass, but you know this ground glass is actually fibrotic because look at those dilated bronchi. And then that subpleural sparing. This is the image to fix in your brain for typical NSIP. Do they all look like that? No, but a substantial amount of the time you will be able to make the correct diagnosis, but unfortunately it's less specific. So most of these people, if it's idiopathic, will still go ahead and get a lung biopsy. And this is why, because there is overlap with UIP, HP, DIP, and even LIP. So there's just more overlap in this diagnosis. As I already mentioned, when you see somebody with NSIP, you should look for signs of collagen vascular disease. You should look for clues to hypersensitivity pneumonitis. Think about drug toxicity. We see a lot of nitrofurantoin lung for some reason, and there's actually a nice poster on that out there that can often look like NSIP. So always include drugs in your differential. Some people believe that smoking may also be associated with NSIP. What happens to people with NSIP over time? Some of them get better, okay? Get better on treatment. I think most of them just say exactly the same. You can follow this. This is a 4-year follow-up, and it looks identical. So it seems to be just a once-off lung injury that the patient is just left with disability. And then there are some people, a minority, who actually progress. They look like this, typical NSIP. They actually get honeycombing. And this, of course, is confusing because it suggests that there's some overlap between NSIP and UIP, and people have done histologic studies as well that show that you can evolve from NSIP to UIP. It's a minority of cases, but you just need to be aware that that can happen. This is a paper from Dr. Silva and Dr. Mueller showing that when they followed these people over 5 years, they basically had an increase in the number of the subjects who looked like UIP or IPF. So it's something to bear in mind. Now, so a lot of our practice, as I said, is the fibrosing interstitial pneumonias, and you're sitting there trying to figure out, it's typically, is it chronic HP, is it UIP, or is it NSIP? What are the features that help us make that diagnosis? Another paper from Dr. Silva shows that honeycombing, as we already said, is uncommon NSIP, should make you think of chronic HP or UIP. Lobular areas of decreased attenuation should strongly suggest chronic HP. I showed you an example of that already, and likewise centrilobular nodules. You have to look for those findings. And then the presence of subpleural sparing is the best predictor of NSIP. And then the last thing is if you have lack of lower lung predominance, if you have mid or upper lung predominance, then you really should think about chronic HP. Smoking-related lung diseases we're going to talk about very quickly. Respiratory bronchiolitis, the dirty lung appearance, centrilobular nodules, patchy ground glass. When you have more extensive ground glass, it gets the label respiratory bronchiolitis interstitial lung disease. That's a more clinical label. And then with DIP, the clue to the diagnosis is the ground glass abnormality, often associated with cysts within the ground glass. RB is usually mildly symptomatic, RB-ILD, and DIP usually much more symptomatic. This was a paper from the New England Journal last year. We looked at 2,400 cases of this in the COPD gene study. We actually found 194, 8% of this population had some sort of interstitial abnormality, usually ground glass abnormality. Clearly it was related to current smoking and pack years. They actually were less likely to have COPD, more likely to have a restrictive physiology. So it is a common finding in people who are cigarette smokers. Talk for just a couple of minutes about organizing pneumonia. You're all familiar with this at this point. Patchy consolidation, like the word says, it's an organizing pneumonia. Often it's either subpleural or peribronchial, and sometimes associated with ground glass. Relatively nonspecific, there are a lot of causes of lung consolidation. Two clues to the diagnosis would include this perilobular thickening. Dr. Franquette showed an example of this morning in a post-infectious organizing pneumonia. So this irregular thickening of interlobular septa should lead you to at least wonder about organizing pneumonia. And actually in our practice, we see this particularly with the drug toxicity like nitrofurantoin. And then the other classic clue to the diagnosis is this reverse halo, peripheral consolidation, central ground glass abnormality, also called the Atal sign. Again, these are just patterns of lung injury. They can be cryptogenic, but they can also be collagen vascular disease, drug toxicity, aspiration, or even, as was shown this morning, infection. So again, you have to include a broad differential and not assume it's cryptogenic. What about multidisciplinary diagnosis? We all say, oh yeah, it's great to get together and, talk about cases and that sort of thing. Does it make a difference? So there are a couple of papers like this, two from the Michigan group, and this is one from Dr. Flaherty, where they looked at 58 cases, suspected IIP who'd undergone biopsy. They underwent independent review followed by clinical radiology pathology consensus. During the consensus review, 50% of the time, the radiologic diagnosis was changed. That's not surprising because these people also all had to undergo lung biopsy for diagnosis. So the biopsy changed the diagnosis. 30% of the time, the clinician diagnosis was changed. That's largely because the clinicians had access to the imaging as well as clinical details. But the important point is 19% of the time, the pathologic diagnosis was changed. And what drives that change? It's imaging. It's finding upper lobe predominant disease in someone with an NSIP pattern. That means you think it's HP. You find other features like mosaic attenuation. Those are the features that we identify that you have to stick to your guns even if the pathologist offers a different diagnosis. That's why this is important. So in summary, I hope you've seen that we're now trying to be more less list-driven and more organized about classifying the idiopathic interstitial pneumonias into fibrosing and non-fibrosing entities. That honeycombing, which you all knew, is the most important distinguisher between UIP, possible UIP, and non-UIP, and that multidisciplinary diagnosis makes a difference, and sometimes the radiologist is right.